Hey, what's up guys? J.A. Graves here with Physical Therapy Clinical Development. In this video, I'm gonna talk to you about everything upper extremity neurodynamics. So we are gonna talk about selective tensioning techniques for the median nerve, selective tensioning techniques for the ulnar nerve, and selective tensioning techniques for the radial nerve. In addition to selective tensioning or neurodynamic testing, I'm also going to cover treatment strategies. How can you treat a neurodynamic issue as the clinician? So different ways to do sliders and tensioners, as well as, and perhaps most importantly, self-care options for the patient. Again, covering the median, ulnar, and radial nerves. Enjoy. Before we get too far into the examination of the median nerve, let's go over some anatomy. So looking at the median nerve, we see that it comes off of the C5 through T1 nerve roots. From there, it's going to course down across the shoulder joint. You can see that it goes anterior, inferior, and medial to the shoulder joint. Hence the reason that abduction and external rotation will put tension on this nerve. From there, the nerve is going to course down and go down past the elbow medially. And then as it comes down towards the wrist and the hand, it kind of crosses over to be a little bit more radial. So again, these also explain why things like supination, wrist extension, and thumb extension will put more tension through this nerve. All right, now that we've reviewed the anatomy, let's go over how to selectively tension the median nerve. We're going to start with the arm and abduction, and from there we're going to add wrist, finger, and thumb extension. From there, we'll supinate the forearm and externally rotate the shoulder. The final component will be elbow extension. Now, if we want to get more tension or less tension, we can add cervical spine movement. So if she were to laterally flex away, that would increase tension, or laterally flex towards, that would decrease tension through the median nerve. Now that we've covered anatomy and selective tensioning of the median nerve, let's review clinician-assisted treatment. So in this case, you can use sliders or tensioners to mobilize the nerve. In this particular situation, the patient's arm will be placed into a tensioning position, and from here we can manipulate either proximal or distal components, as well as components, anything along that nerve pathway. So in this case, I'm maintaining wrist extension while adding cervical lateral flexion or side bending in order to glide the nerve. If I wanted to tension, I could have her tilt her head the opposite direction, and I can also manipulate the wrist. So I could maintain the head neck position and use wrist flexion and extension. I can combine wrist flexion and extension with neck movement. I can mobilize at the elbow. I can use supination, pronation, internal or external rotation as well. Another clinician-assisted treatment would be pre-positioning the arm in median nerve tension and doing glenohumeral joint mobilizations. You can also have the patient extend their wrist to get more tension through the median nerve. Self-care may start with the prayer position. Both wrists are extended and forearms parallel to the floor, with side-to-side movement occurring at the shoulder. Another technique to mobilize the median nerve is the wall stretch. So here we have the wrist extended with the elbow extended, and we're rotating the torso to mobilize the median nerve. A variation of this would be opening up the opposite arm as well, which if somebody had bilateral symptoms, this could target both, and then obviously you would switch sides. A more gentle technique can be seen here, where we combine cervical movement with upper extremity movement, including external and internal rotation, supination and pronation, as well as wrist flexion and extension. Another relatively gentle technique is shown here, and this is the yo-yo technique. So this is just like playing with a yo-yo, where you have elbow, wrist, and hand extension. Now let's review ulnar nerve anatomy before we get into selective tensioning techniques. So the ulnar nerve is going to course down from the neck, C8 through T1 nerve roots, down inferior and medial to the shoulder. From there, it will course medial to the elbow as it extends down into the wrist and hand on the ulnar aspect of the hand. So again, understanding the anatomy will help you better understand why we use the movements and the positions that we do. So again, for the ulnar nerve, we've got shoulder abduction, elbow flexion, shoulder external rotation, forearm pronation, and wrist and finger extension, which again should make sense when reviewing the anatomy. When performing a nerve tensioning technique of the ulnar nerve, we're going to use the same movements I just mentioned. So we're going to use wrist and finger extension, forearm pronation, shoulder external rotation, elbow flexion, and lastly, we're going to add shoulder abduction. For this to be positive, a patient will feel symptoms along the ulnar distribution of their arm. As usual, we have clinician-assisted treatment and self-care. So for clinician-assisted, we can utilize the same tensioning position that we used for the examination, and we can add a little bit of movement to either selectively tension or slide the ulnar nerve. So in this case, what you'll see here is the addition of scapular depression as a way to increase tension on the ulnar nerve. Now, if I wanted to have this patient glide the nerve, when I selectively tension by depressing the scapula, the patient might decide to extend their neck, or you might ask the patient to extend their neck. To increase tension, you could depress the scapula and add cervical flexion. So in this case right here, we have a slider taking place, and by having her flex her neck with my addition of scapular depression, this would be a tensioner. Now let's cover some self-care options for mobilizing the ulnar nerve. The first is the smoker. Next, we have a progression to the smoker mobilization called eyeglasses. This can be done bilaterally as shown at first, or unilaterally depending on their symptoms. Another novel way to mobilize the ulnar nerve may include the rib walk. In this case, the hand is climbing up the rib cage or thorax, and you can add side bending through the trunk. The final self-care treatment for the ulnar nerve would include drying the back. So we'll take a towel, hold on to it just like you're drying your back, and you can move the arms up and down to selectively glide the ulnar nerve. Let's take a quick peek at radial nerve anatomy before we jump into selective tensioning techniques. So the radial nerve is going to come from C5 through T1 nerve roots. From there, it's going to descend down the arm. Its branches, you'll see, lie on the dorsal forearm and wrist and hand. So movements such as wrist and thumb flexion will selectively tension this. Shoulder abduction, because of the way the nerve sits medial to the shoulder joint. Elbow extension, as well as shoulder internal rotation. As mentioned in the anatomy review, thumb, finger, and wrist flexion will be performed. From here, we will add shoulder internal rotation and abduction in order to put tension through the radial nerve. Again, you can add cervical spine movements to either tension or take tension off of the radial nerve. I'll first start with clinician-assisted treatments. So just like the median and ulnar nerve, we can include cervical spine movement or wrist and hand movements to either tension or glide the radial nerve. In addition to sliders and tensioners, we can pre-position the patient's arm in that of radial nerve tension and mobilize the radial head. This works especially well if somebody has a radial head mobility problem. And while it's not shown here, you can also do soft tissue treatment to the dorsal forearm in this position. Now here's 3 self-care options for the radial nerve. The first one is pouring out the water. So in this case, as you can see, I'm pouring out the imaginary water. A slightly more aggressive technique would be looking at your hand as seen here. As you can see, we have all the components of radial nerve tension: wrist and finger flexion, forearm pronation, and shoulder internal rotation. And lastly, we have a slightly more aggressive technique where you clasp the hands in elbow flexion and extend the elbows. All right, guys, so that wraps up upper extremity neurodynamics. Hopefully you enjoyed the video. If you are not already in the physical therapy clinical development Facebook group, I strongly recommend you check out the group. It is driven by member requested content. So in other words, I put content in there that you guys want to see and hear and things that are meaningful to you. So again, if you're not already a member, check out physical therapy clinical development on Facebook, and hope to see you in the group soon.